Hello everyone, and welcome to my presentation on point-of-care testing integrated into clinical care, improving cardiac outcomes in rural areas. I'd like to thank the organisers for this opportunity to talk about a piece of work that has been the bulk of my professional life for the last 13 years. Okay, sorry. A considerable body of work has been done around the inequity of cardiac outcomes in rural and remote areas, and a paper by Sexton in 2000 actually reported that more deaths than expected occur from acute myocardial infarction in rural and remote areas, which resulted in higher mortality rates from coronary heart disease, approximately 30% higher in men and 21% higher in women living outside of capital cities. If you think about the factors that contribute to the geographical variations in coronary heart disease outcomes, they include your demographics, your age, sex, ethnic background of your population, socioeconomic factors, risk factor prevalence, smoking, lipids, hypertension, diabetes, obesity, sedentary lifestyle, and of course you've got treatment factors involved in individual cases. If you look at South Australia, where I come from, you can see we have a vast geographical area. Our area, although larger than a lot of European countries, has only a fraction of the population, perhaps a 30th in some instances or 40th of the population. So that brings about huge challenges when delivering health services. If you look at the yellow stars on the map, that's where the pathology laboratories are located. So you can see there's vast areas where there are no pathology laboratories for hospitals or the patients in these areas. So our rural health service has a population of around 420,000 people. 14% of these people are greater than 65 years of age. We have 66 country hospitals providing 24/7. A couple of smaller sites now no longer provide 24/7 cover, but there is a close regional hospital that takes care of that. The catchment populations are anything from 1,500 to 30,000 per hospital. As I mentioned, there's only about 10 on-site laboratories in the rural areas. We have a significant shortage of doctors and nurses in primary care and hospitals, and have a high proportion of overseas trained doctors working in South Australia. There's a significant shortage of medical specialists, and there's only 3 adult consultant physicians operating in rural areas. And teaching and tertiary hospitals are highly centralised. In terms of the bad in our Australian healthcare, we're highly urbanised, which the map shows certainly for South Australia, with extremely low population density outside of the major urban centres. Our health centre is very fragmented. There's barriers between the Commonwealth and state-to-state barriers, and of course you have your metropolitan, regional and remote barriers and differences. And we have a real lack of health information systems across Australia. So we have a lack of systems for safety, quality, and cost effectiveness, and really our systems are unsustainable in terms of inequity of outcomes, inefficiencies. There's over-dependence on acute hospital care and the workforce capacity. Along with the bad, we actually have a changing practice environment with increasing numbers of the elderly, much more chronic disease that we have to deal with. There's workforce shortages, I've mentioned already, medical cost pressures, increased demand for patient safety, increased demand for optimal and equitable outcomes, and really universal application of medical evidence, making sure that we are practicing evidence-based care. There's rapidly evolving therapeutic possibilities and new technology, some of which are hard to implement in our rural and remote areas. We have a demand in our changing practice environment for increased efficiency, increased throughput and cost effectiveness. Really there's a greater accountability for processes of care and outcomes, and we're trying to remove the barriers and impediments for evidence-based care. We have to really embrace new ways of delivering care and have a more team-based, multidisciplinary care. Clearly, we want a patient-centric model of care. There's role redefinition, a one-stop care, really, clinic, home-based delivery, local capacity. And we need to re-engineer and redesign how we actually are offering our health services to be more efficient. And of course, we do need the data collection, analysis and feedback integrated into the process of care for continual quality improvement. So what is our problem? Well, coronary heart disease incidence, morbidity and mortality rates continue to be higher across all groups in rural and remote areas compared with the urban areas in Australia. The practice of cardiac care differs according to the geographic location, specialty of the practicing physician and teaching status of the hospital. A lot of prior to implementing point of care, a lot of our rural health centres had to wait up to 24 hours for routine blood tests, which were commonly available in urban areas between 1 and 2 hours. So, you know, from a perspective of a troponin, if you were a little remote hospital that was 4 hours away from a laboratory, you may actually have to wait 24 hours and on the weekend even up to 48 or more hours for a result. And clearly, that test becomes not part of the timely medical service. You actually have to triage a patient without that test. So our research question when we started this project was, does the limited access to evidence-based care in rural areas, that this may be explained by the access to care may explain the differential in outcomes between coronary heart disease in urban and rural population. And that was the hypothesis for our research. So we started our research and we actually were successful in getting a Commonwealth grant to look at this. And what we did initially is consulted with the rural clinicians trying to identify the 3 areas for improved patient care. What was preventing them from practicing evidence-based cardiac care. And the 3 things that they really were quite uniform about were the need for advice with ECG interpretation, better access to biochemical markers within the recommended time frame, and access to advice from a consultant cardiologist. So we set about trying to come up with a solution to these issues, and iCARnet, which is now known as iCCnet Country Health South Australia, was established in 2001. It was established to support rural GPs in the delivery of up-to-date evidence-based management of patients presenting with chest pain or other symptoms suggestive of acute coronary syndrome in the southeast of South Australia in the first instance. It was designed to support GPs by providing bedside cardiac marker testing, evidence-based triage and management guidelines, and a 24-hour on-call cardiologist. We received in 2006 funding of 1.3 million over 4 years, which was announced by a health minister, to actually extend our research project, which was looking to be quite well accepted and successful throughout the country region. So what were the principles and objectives of our program? Well, they were to support the primary care doctor in the diagnosis of acute management of cardiac conditions. It was to enhance the clinical autonomy of the primary care doctor and promote the importance of primary care doctor-patient relationship. We didn't want to come in and take over. We really wanted to be their support base and be there in the background if they required our assistance. We needed to accommodate different levels of experience and different confidence levels of the doctors dealing with the acute cardiac problems in their hospitals. So our way of doing this was to bring together all the participants in rural cardiac care. And this included getting hospital management buy-in, engaging the primary care doctors, engaging the regional consultant physicians, the emergency and cardiac nursing staff, the community and regional hospital services, including emergency departments, coronary care units, HCUs, bringing in point of care pathology, engaging the cardiologists who supported these hospitals, the intensive care and retrieval service, ambulances, and the surgeons who had to do the invasive surgery when required for these patients. So enablers of our clinical networks, or our clinical resources that we used, were integrated evidence-based clinical pathways for chest pain and acute coronary syndromes. They were triage protocols, they had diagnostic risk stratification protocols and treatment protocols, and these are all rolled into one, and I'll show you what it kind of looks like in a minute. We introduced point-of-care pathology in all these hospitals, and so for the first time they could actually get a troponin result within 15 minutes. And we set up a system so they had improved accessibility, consultant cardiologists advice 24 hours a day, 7 days a week. And we monitor the response time, and our performance indicator is that we will respond to these requests within 10 minutes. And we meet that probably about 85% of the time. We had to improve access to tertiary cardiac services through service integration. We came up across an issue where the thrombolytics for ST elevation MI, a lot of our hospitals didn't have it because it was expensive. They didn't use it, they would be throwing it out because it would expire. So we set up a rotation system with all our hospitals to ensure that everyone had the drug, and minimum amount of the drug would be thrown out. We were always interested in cardiac rehabilitation because, of course, once these people had an event, something had to be done to educate them on how to deal with their disease. Of course, staff training and CME was extremely important, bringing people up to speed of what the evidence base was for cardiac care. And without doubt, IT is extremely important to what we do. So, what was the role of point-of-care testing in our initial setup? Well, point-of-care was really required to enable risk stratification of the cardiac patients. It was critical to developing evidence-based cardiac care in our rural areas. It was designed and implemented. We designed and implemented a cardiac network incorporating point-of-care, run within a quality framework. The physician acute needs resulted in an expanded range of point-of-care tests, which we've slowly been introducing as time goes on. This is the big pathway that sits in our emergency departments, and you guys probably won't be able to see it very well on your slide, but it basically tells them what to do as the patient hits the emergency department, what drugs to consider, what tests need to be done, when the troponins need to be repeated, when they need to consider transferring them to Adelaide for invasive testing. And it's really the Bible of acute coronary syndrome in their hospitals. It's endorsed by the Cardiology Clinical Network, and it's a very popular pathway in our emergency departments across our 66 hospitals. So point-of-care troponin differentiates between unstable angina and non-ST elevation MI. That's really the main purpose of using troponin as a risk stratification tool, because there are slightly different treatments for unstable angina versus a non-STEMI. It really enables us to have an informed decision on which patients need to transfer to tertiary hospital for invasive cardiac testing, and really prevents the unnecessary transfer of patients who are low risk for acute coronary syndrome and can be managed safely in their local hospital. Before we set up these protocols, when we reviewed what patients were being transferred, there were even stable anginas that could quite easily have been managed in their own town with less disruption to the family unit that were being transferred to Adelaide. So certainly our systems have improved. We have increased transfers because that's part of the evidence base, that high-risk patients do need to transfer to Adelaide, but we've stopped the transfer of the patients who don't require it. So we had to implement point-of-care really across all our hospitals. We did this with on-site training. Further training is supplied via video conferencing. We're lucky in South Australia that considerable amount of money's been put into video conferencing across all our hospitals. So across our health network, we can actually video conference into every hospital and provide training and education. That same video conferencing equipment is used for clinical consults, emergency clinical consults, for cardiology, and certainly psychiatry in particular, which is what initiated the setup of the video conferencing suites in country. So it's a fantastic resource, and it really helps us support all our hospitals without having to travel to them all the time. We also use webinars for continuing education on point of care testing, both technically and clinical reasons for it. All our hospitals have documentation on all of their point of care methods. They actually have a folder with all this information, and on our website there's online copies of basically all the information that they require to run their tests. We have, as well as having the cardiologist support, we have a technical support hotline as well. So there's a clinical scientist that's on call 24/7, and we're really on call to support them if people who may not use the equipment very often and need some prompting along the way, or if there's an error. And some of the things we can sort out, and sometimes clearly we can't. And our way of troubleshooting is if we can't sort it out with some basic, getting them to answer basic questions and check some basic things, we then basically have to pull that instrument, and rather than go out there to have a look at it, which is not well, we need lots of staff to be able to do that, we have spare instruments in town and we send it overnight to the hospital. It does sometimes mean that these hospitals may be without the technology for a wee bit, but that's probably the best we can do. In sites that have a high throughput of patients, we tend to have at least 2 machines there to cover those instances. But we've been pretty lucky, touch wood, that most of the equipment we choose has been extremely reliable for us. So we have a training program. As I said, we have a variety of ways of offering that training program, and we really go through the performance characteristics, how to get a good, the patient preparation and sample collection, because of course if you don't have a good sample, you're not going to get a good result. Reagent preparation, storage, how to perform the tests, the principles and practice of quality control and external quality assurance, maintenance and common troubleshooting, although most people, I have to say, their troubleshooting is to dial the technical support line, occupational health and safety issues, compliance with accreditation, recording of results, interpretation of results, and really where do they go if they need help. We have a quality program throughout iCCnet. It's mandatory for the sites to participate in both the internal and external quality programs. When we first started, excuse me, we were essentially an external provider. We were part of another health network, and we had to get the agreement from management before we started into the hospital with our program. These days, as I'll talk a bit about later, we're actually part of Country Health, so that makes it much easier. We come up with recommendations on how point of care should be run throughout country, and those rules and regulations have to be followed across all our hospitals, and certainly participating in quality control programs is high on our list of what they have to do if they want to continue doing testing. The sites submit the results to the iCCnet office every month. That's actually changed now because we have gone electronic, and I'll talk a little bit about that soon. With their EQA, we send out monthly reports to the hospitals to let them know how they're doing and how their result compares to everybody else in the traditional EQA way. Our nurses perform the QC tests. When we actually distribute all the consumables from our central office, and before we do that, we do run batch QCs in our office to make sure that the lot numbers we are sending out are appropriate. We do have some challenges across 66 hospitals that we run, and that's nursing staff who have lots of jobs, and there's certainly, as I said, a shortage of them, remembering to do the QC and QA. Most hospitals understand the need of it, and it's not that they don't want to do it, it's actually just remembering to do it. A lot of hospitals rely on one nurse to perform the QC and the QA testing. We try and discourage that and have it that when it's due, whoever's on shift will do it. But we still haven't converted all our hospitals, I don't think. Clearly, sometimes the storage and reconstitution of the samples is a bit of an issue, and I'll show you how we sort of rectify that. Correction action on discrepant results, getting them to actually report them to us. we have to transport frozen liquid QC, QA samples across, vast distances, and that is challenging, particularly in our summer when it's extremely hot, and we run the risk of the samples being destroyed before they even get to our hospitals, and of course the costs. This graph shows a site where we were finding their internal QCs for troponin were probably much more variable than what we had hoped. So we were concerned that perhaps it was to do with the making up of the QC. So what we started to do was actually make up the QCs in our central office and send them the frozen sample. And interestingly enough, you can see that really tightened the CVs considerably. So we then had to sort of do some education on reconstitution and the importance of making sure the right volume and the right time, and doing the test in appropriate time frame to get these tightened CVs. So what are the benefits of point of care within a clinical network? Well, clearly you can have standardised instrumentation and method selection across a network. And that's extremely important to us, in particular for troponin. If we had some sites who did a troponin T and some who did an I, that would be problematic. Not that I is a bad marker, it's just that the cardiologist on the phone would have to remember to ask which method are you using and what is your reference interval. This way we have one test and the cardiologists on call are well aware of how that test performs, the limitations of that test, and it certainly doesn't cause us any sort of errors in terms of result interpretation. Being within a clinical network, we can integrate the test into a clinical pathway, as I showed you that big pathway that we have on our emergency department walls. We have one policy that's shared amongst all our health centres, and there's central management of training, support and QC monitoring. We have for our 66 hospitals, in addition to myself, we have 3 other medical scientists that support the point of care network in country. So the important features for a point of care service which is managed off site is really selection of appropriate equipment, because if you have good equipment and have good training and education around that use of that equipment, you don't have a technical support line that gets lots of calls. We currently, out of hours, would maybe get a couple of calls a week. We tend to get most of our technical support calls during the day, and it's usually around QC, QA, or using our databases. So we're quite pleased that the level of training we give our sites is adequate enough, because we don't get a lot of please help calls. It's important that the nurses and doctors have really a good clinical understanding of the results. Normally the results are done in a pathology laboratory, and the lab really acts as a safety net for those results before they go out to clinicians. With point of care, you're removing that safety net, so the doctor has to be aware of issues that might affect that result, in particular, the pre-analytical issues. You need clear, concise instructions for your methods. Electronic capture of QC results is great. Technical support clearly is important. Having good troubleshooting mechanisms, and IT. Without IT, basically the challenges are tenfold, I'd have to say. So if you look at our network implementation timelines, the project commenced in September 2000. That's when I commenced working on the project. We had our pilot network in 2001. In 2003, we had the fully regional network, which was completed across the southeast, and that was funded by the Commonwealth Government. A commitment to go statewide went around 2004, and that's really because all the hospitals started learning about the service and ringing and saying, please can we join, please can we join. So even though we weren't really funded to do all of country, we started creeping out into all country towns that wanted the service. The statewide network was completed basically in 2008. In 2010, Country Health, that had been funding that network since 2006, decided to incorporate the research network basically into their clinical service. So we became the cardiology department of Country Health. So I'd have to say this is one of those exciting journeys where your research actually translates into a clinical service. And now myself and my staff, rather than having to get budgets and grants every 3 years, we are all just temporary employees, permanent employees rather, of Country Health in South Australia. So our network is really patient focused, evidence-based, it's systematic, it's comprehensive, and population level focused. But the most important thing is that it is a patient-focused network, and we'll do everything really in our power to ensure that the rural patients get the best cardiology care that they can. If you look at the clinical resources we use in our hospitals, we, over the last couple of years, have installed a digital ECG management system, which really gives beautiful digital images of ECGs, which can be emailed to the on-call cardiologist. It means that across country, any patient can review ECGs from any other hospital within Country Health, and certainly they can call up previous ECGs and see if the changes are new or if they're already there. Our paging service, just to give you an indication, it's a 24/7 service. The aim is less than 10-minute response time. There's a single statewide telephone number, and it has a built-in redundancy. So there's the cardiologist who gets the call has to actually accept the call, and if he doesn't, it goes on to the next cardiologist who's on call. We at any one time have 5 cardiologists on call, and at the end of the line it reverts to the technical support hotline, and us scientists will then not respond to the call clearly because we're not cardiologists, but we'll find a cardiologist to take that call as soon as we can. These are the instruments that we have in our network. The extended care point of care that we actually use, NT-proBNP, of course, for your heart failure patients, D-dimer, hemoglobin and white cell count is increasingly getting popular. As of last June, now all our hospitals can do basically troponin and their electrolytes and blood gases. So Country Health put up the capital to put, we actually went with the EPOCs into our country hospitals. So we do have a few iStats out there, but because of the EPOC having room temperature consumables, it's much more suitable for us in a rural network. It's easier to transport items. So that was a fantastic achievement, really, to know then that a basic electrolyte and blood gas could be done in all of our hospitals, when previously, if they needed monitoring of their electrolytes, they would have to be transferred to Adelaide to get that done. We actually, over the last probably 18 months, have been developing a point of care pathology database, and the system is really designed to accept pathology requests, record and chart patient results, generate pathology reports, download and chart quality control results, excuse me, order consumables and track usage. It's web-based, and it's actually sits in our demilitarised zone in health, which makes it accessible to our doctors who are outside of the health network to retrieve these results. We are about to actually launch our ECG database, which sits on the intranet and can't be viewed outside of health. We're actually about to get the ECGs also transported to our point of care database, and so doctors will be able to retrieve their point of care results and the ECG results from their surgeries or at home at night if they're on call. So that's a huge achievement for us as well. So this is just a look at what our pathology request form looks like. Our database looks like here. We have tabs for the different panels of tests, so they're easier to view. And that's just an example of a pathology report it can generate. So it does have the reference ranges. And although we're not a laboratory, we do try and follow pretty much what laboratories do in terms of quality framework and reporting of results. So the big question is, has iCCnet really made a difference to cardiac outcomes in South Australia? In the first 12 months, we did do a retrospective audit of chest pain and ACS presentations. Basically in the southeast, we had 6 sites that were part of the network, and then we had the major regional hospital that wasn't. And they really almost gave us a kind of a nice controlled study. So we actually compared the patterns of care between the hospitals involved with the network and the big regional hospital that wasn't involved with the network. The inclusion criteria was that they had to have a history suggestive of myocardial ischemia and have had at least one troponin estimation. If you look at the evaluation data, what was most important and one of our performance indicators was that you had to have if you're a high-risk cardiac patient, you had to have an angiography between 48 to 72 hours. If you looked at the non-iCARnet sites, the time to an angiography was about 6.3 days. In our network, we had reduced that to 3.2 days. So that was really promising. And it looked also like the readmissions for these patients was considerably less in our network. This data across the regional southeast was really quite exciting for us. And you can see the black line shows the southern metropolitan area, and it shows you on the y-axis the in-hospital deaths for acute coronary syndrome. And you can see that in the southern, the black line, it started off high, but it actually then plateaued around 4%. The red line is the southeast moving average. And if you look at that as opposed to the blue line, which is the actual results and bounces around a bit, the red line, also in country, you can see the ACS regional deaths was high, but considerably higher than the metropolitan region. The network commenced in 2001, and you can see that indicated on the graph. The fully regional network started in 2003, and you can start to see that the two lines merge. Those lines continue to merge, and so that was, to us, was really exciting. It looked like we were making a difference in the in-hospital mortality for acute coronary syndrome in our research area. We just this year, February this year, we reported on the impact of our regionalised network across South Australia, and if you're interested, that paper's in the Medical Journal of Australia. So the conclusion to that paper was that cardiology supported remote risk stratification management facilitated early access to tertiary-based invasive management was associated with an improvement in 30-day mortality for patients who present to rural hospitals and are diagnosed with MI. These interventions closed the gap in mortality between rural and remote, rural and metropolitan patients in South Australia. So if you have a look at this graph, and this is 30-day mortality for AMI between 2001 and 2010, the red line shows the metropolitan observed rate, and the blue line shows the rural observed rate. And you can see even with this regional data, the two lines have merged and come together. So we have eliminated that mortality gap, which is extremely exciting to us, and probably explains why our research is now no longer research and it's clinical care within country health. This graph, actually, the shaded area shows you the uptake of iCCnet and joining the network, and then you can see the light grey line is the metro and the dark line is the rural. And again, as the uptake of iCCnet increased, you can see that the 30-day mortality decreased. So if you looked at the risk-adjusted odds ratio for deaths at 30 days, post-MI for rural versus metro. In 2001, that risk odds ratio was 1.69, and in 2010 it was 0.92. So the implementation of iCCnet model of care in rural hospitals was associated with a 22% reduction in 30-day AMI mortality. The beauty of this was that it wasn't really an expensive system. It was really, what was needed was to integrate all of the bits into a system of care and to make sure all stakeholders were aware of the standard process of dealing with patients and offering education and, of course, technical and clinical support. So what lessons did we learn over the last 7 years? Well, you need a quality framework, and it has to take into account the limited resources in a busy clinical environment. It has to be not onerous but effective when you're implementing new systems. There has to be flexibility in training programs. You need to have good communication with all sites. Technical support for the point of care was extremely important. The times that it is used, it is critical because they have a very sick patient that relies on that result. Integration into clinical care, incorporating all stakeholders involved in patient care, that was extremely important. If you had engagement of all, it was more likely to be success. If you just put in the point of care and didn't have any engagement with clinical clinicians, it was highly unlikely that they would trust that new technology or even use those results. Multiple modes of training are required in a dispersed network with limited resources. So a summary is that point of care has improved provision of necessary tests regardless of geographic location or size resources of the health facility. It has enabled re-engineering of delivery of services to improve patient safety, clinical outcomes and efficient utilisation of resources and improve capacity. The provision of point of care was necessary, but not really on its own sufficient for the success of this practice improvement initiative. And most definitely point of care should be part of an integrated approach to practice improvement initiatives. So in conclusion, our network spanning 980,000 kilometres based on specialist support and point of care combined with integrated diagnostic treatment and triage protocol has improved the uptake of evidence-based acute cardiac care for patients with acute coronary syndrome in country South Australia and has improved patient outcomes. Okay, thank you everyone, and I hope you found that interesting. Okay.